And it really was, for me, a great honour to be involved in the judging of the prize. So I did it in conjunction with Mark Stevens, who's in the audience. And sometimes when you're asked to do these things, it's a bit of a chore and it's a bit of work, and you've got to look through a pile of information. And I have to say, this really was a pleasure. We had 5 nominations, and they were all excellent in their own ways. And I think maybe reflective of the fact that these were infectious diseases, PhDs, they were all really relevant for what they were doing. So very different, a lot of different projects, but really relevant and really great impact. And we looked at a whole number of criteria. We didn't just stick to the old, you know, what's the highest impact papers and how many papers and that sort of thing. We looked at a whole number of things. Having said that, I'm not going to take anything away from the winner, who has a very enviable publication record given his early stage in his career. And in fact, from last year, 2 really fantastic papers, which I'm sure will be in the work that he's going to describe to us. And also early this year is a joint first co-author on a Nature Reviews in Immunology paper. So I think very impressive for a PhD student, and reflects really great on Edinburgh and on Edinburgh Infectious Diseases. So the winner this year, who I'd like to invite down to collect the prize and also give the talk, is Chris Lucas, who was at CIR. And Chris's project, as he will tell you, was, we've heard quite a lot today about inflammation, but this was about targeting a pathway in neutrophils in relation to apoptosis and bacterial clearance to reduce inflammation, and really fantastic work. So we had great pleasure in reading it. So first of all, I think we should congratulate Chris.
Well, first of all, thank you to the organisers and also the Ker Memorial for inviting me along to speak today, and also for a great introduction. So I'm going to be talking about some of the work that I did as part of my PhD in the CIR here in Edinburgh. And I'm going to be primarily talking about these cells here called neutrophils, which, as everyone knows, is a central component of your cellular innate immune system, whose main role is to destroy invading microorganisms. And they can do this by a variety of quite different mechanisms. They can internalise pathogens by phagocytosis. They can release all these toxic cytoplasmic granules into extracellular space. They can produce reactive oxygen species. And as has been more recently described, they can also extrude DNA studied with antimicrobial peptides to ensnare and kill pathogens. And their importance is really revealed by defects in either number or functional status, either in humans or in animal models, which leads to recurring life-threatening infection. However, these are very unusual cells in that under basal conditions they're very short-lived. These are some human neutrophils isolated from blood of healthy volunteers, including myself. And if you put them in culture and do nothing else to them, what you tend to find is that they die very quickly with a half-life of about 12 to 14 hours. And the way that they die is by undergoing apoptosis, which is a form of programmed cell death. This is an energy-dependent process with a number of different hallmarks. What's great about neutrophils is you can see this very easily. These neutrophils here are freshly isolated. They've got a nice multi-lobe nuclei and are nice and healthy, whereas these cells that have been aged in culture have nuclear condensation and cellular shrinkage consistent with spontaneous apoptosis. So these cells are very short-lived basally. However, when you get an episode of tissue inflammation or infection, the cells are recruited to these sites where their lifespan is markedly upregulated, and that's driven by a variety of host-derived factors, pathogen-derived factors, as well as changes in the local microenvironment. However, once the inciting stimulus has hopefully successfully been dealt with, it's really important that all these non-tissue resident cells are cleared to allow the organ to return to homeostasis. And it's thought that a major clearance mechanism is, again, by local apoptosis, and then clearance by surrounding cells, including macrophages and epithelial cells. And it's thought that these processes of apoptosis and subsequent phagocytosis are key to the successful resolution of neutrophil-dominant inflammation. However, this doesn't always go quite to plan. You can have inappropriate neutrophil recruitment or inappropriate neutrophil longevity, or you can have the cells dying by other methods such as primary necrosis with release of all these toxic contents into their environment, and this perpetuates inflammation and impairs pathogen clearance. And this is a clinically relevant topic with unresolved neutrophilic inflammation seen in a wide variety of inflammatory diseases, both sterile and infection-driven, including pneumonia and sepsis. And what we know is that low levels of neutrophil apoptosis correlate with mortality in sepsis and sepsis-driven acute lung injury. So how does this all relate to pneumonia? Well, pneumonia is an acute respiratory infection that's driven mainly by bacteria and viruses. And of course, in this antibiotic era, the answer to this is just to get some antibiotics from your GP and you'll be absolutely fine. Which kind of begs the question is, why is this remaining the leading cause of death in children under 5 worldwide? This is not just a third world problem. Pneumonia remains the most common fatal infection in the developed world. And it's rather sad to say that if you get pneumonia today, you've got the same chance of dying as you did 60 years ago. And that's despite improvements in antimicrobial therapy and improvements in hospital care. So why are people dying from pneumonia? Well, if you get community-acquired pneumonia and make it into hospital, then less than half of patients you can actually identify a pathogen from, which suggests that ongoing, persisting and uncontrolled neutrophilic inflammation may well be relevant to the disease process. In addition, pneumonia, as shown in this chest x-ray here, frequently progresses to this condition here with this diffuse white inflammatory process throughout both lungs called acute lung injury. This is mediated by neutrophil recruitment, accumulation of proteinaceous edema fluid, and if you get this, this is really bad news. Your chance of dying is unfortunately up to 40%. So the PhD that I was working on was really looking to see whether we could target this pro-resolution part of the inflammatory cascade as a potential anti-inflammatory therapy. And the central hypothesis that we set out at the beginning was that lung injury associated with infectious agents could be modulated by strategies that affect apoptosis of neutrophils. So how are we going to do that? Well, cyclin-dependent kinases are traditionally thought of as key regulators of the cell cycle, with inhibitors of these kinases developed as anti-cancer agents. Now, the prevailing view is that neutrophils don't divide, although whether that may well change with time we shall see. So you would maybe expect that these drugs would have no effect on neutrophils, but it has of course been previously shown that CDK inhibitors like roscovitin accelerate neutrophil apoptosis, and subsequently it's been going on to show that neutrophils contain a range of different functionally active CDKs within them. So the CDK that I concentrated on, and I think I'm going to show you exclusively data about today, is this compound with the very catchy name of AT7519. This is a compound that is currently in phase 2 clinical trials as an anti-cancer agent. It's a water-soluble compound, so it's really quite easy to deliver. And I'm going to start things off just by showing you a little bit of model, little bit of data, not from an infectious model, but actually from a sterile model, just to set the scene. And what we did is we set up a model of LPS-mediated acute lung injury. So LPS, component of gram-negative bacteria. We gave this straight into the lungs of some mice, waited 24 hours, gave our CDK inhibitor, and then had a look to see what effect that had. And if you give LPS into the lungs, it looks a bit like this. You get a predominantly neutrophil-dominant inflammatory process with lots and lots of neutrophils and a fair few macrophages as well. So we gave our CDK inhibitor right at the peak of inflammation, and what we found is we had a very rapid and marked decrease in neutrophil numbers. The other thing that you can see from here is that our model is a spontaneous self-resolving model, so even if you do nothing and just wait it out, then things do eventually get better. And we can quantify this by using a concept called the resolution interval, which is really quite a bit more simple than it sounds. All it is the time it takes for your neutrophils to go from their peak down to their half maximal amount. And by giving our CDK inhibitor, we could alter this from about 20 hours down to about 8 hours. So where are all these neutrophils going? Well, if you look at the neutrophils themselves, it gives you some idea. In our control animals, the neutrophils look nice and healthy. They've got this lovely multi-load nucleus. Whereas in our animals that have had our CDK inhibitor, the neutrophils look a bit different. They've got nuclear condensation, the cells are shrunk, suggesting that these are undergoing apoptosis. And if you look at the macrophages, you see increased numbers containing apoptotic bodies, suggesting that these are being cleared in vivo. So certainly we're getting rid of the cellular component of inflammation, but what effects is that having actually on organ function? And one of the ways that you can look to see how the lungs are working is to look at alveolar capillary barrier integrity, or lung leak. And you can very simply measure this by looking at either total protein or other markers such as IgM in the lavage fluid. And what we found is our CDK inhibitor improved this as well, suggesting we were not just getting rid of inflammatory cells but also affecting overall function. So that's what happens if you give it in sterile inflammation, but the big question was really what happens if you get rid of some of your neutrophils when you've got infection. So to do this, we set up a E. coli model of pneumonia in the mouse. So we gave 1 × 10⁶ colony forming units of live E. coli, which had been grown to mid-log phase directly into the lungs of mice. Now this causes a fairly severe pneumonia, again neutrophil dominant inflammation, and also some red cells indicating alveolar hemorrhage as well. And if you look even at 24 hours after administering the E. coli, it's very easy to recover large numbers of bacteria, both from the lung tissue and also the lung lavage. So initially what we thought we would do is we would give E. coli, and then subsequent to that we would give our CDK inhibitor along with an antimicrobial agent, in this case a compound called ceftriaxone. And what we were thinking is that if we gave something that targeted the infection with an antimicrobial and something that potentially targeted the inflammation, then whether that would be better than just antibiotics alone. So there's four treatment groups here. First is just our PBS control. Then we have E. coli alone, E. coli with our antimicrobial ceftriaxone, and then E. coli with antimicrobials and our CDK inhibitor AT. And what we find is that there's a stepwise reduction with antibiotics reducing inflammatory cell infiltrate, which is further reduced when we give our CDK inhibitor. And this is really just a reflection on what's happening with neutrophil numbers, which shows a very, very similar picture. So this is in lavage fluid, but what about the actual lung tissue itself? To look at this, we used a flow cytometry method just to look at our CD45 Ly6G positive cells, which are the neutrophils. And again, you see a similar sort of pattern with an improvement with antibiotics and a further decrease with our CDK inhibitor. So it certainly looked like we were getting rid of neutrophils within the lung, but what were happening to neutrophils elsewhere? And so we looked at circulating neutrophils within the blood and also bone marrow derived neutrophils. And interestingly, what we saw is that essentially there was no real change with either antibiotics or our CDK inhibitor, which suggested that there was a relative specificity for inflammatory cells that had been recruited in to counteract the infection. And when we looked at markers of lung leakiness, again protein and IgM, what we found is that what really made the big difference was having an antibiotic on board with no convincing additive benefit from our CDK inhibitor in this model. So that was the sort of inflammation arm of things, but what happened to the bacteria, which was the slightly nervous overnight as I was waiting for all these bug plates to develop the following day. And what we found is that in the lavage fluids, the antibiotics completely suppressed recovery of bacteria. However, if we looked at the lung tissue itself, there was reduced numbers of bacteria with our antibiotic. And although this wasn't statistically significant, it actually looked like there was potentially an additive benefit with addition of our CDK inhibitor. Certainly it didn't look any worse, which was very, very much reassuring. And just to say that we did have a look elsewhere in blood, liver and spleen just to look for any evidence of systemic dissemination of infection, and we didn't see any evidence of this in either the ceftriaxone with or without our CDK inhibitor. So that led to the question, well actually what would happen if we just gave our CDK inhibitor and didn't give antibiotics? So to do this again we gave E. coli, then gave our CDK inhibitor and had a look after that. And what we found, perhaps unsurprisingly, there were less neutrophils both in the lavage fluid and within the lung tissue themselves. And in this model we reduced our resolution interval from about 50 hours down to 16 hours with addition of our CDK inhibitor. And again, when we looked at circulating neutrophils, or when we had a look at mononuclear cells within the lavage, these were unchanged. And looking at the histology, by this time point the inflammation was predominantly perivascular, so a blood vessel here, and that was improved with presence of our compound AT. So the million-dollar question is what happened to bacterial clearance? And when we looked in the lavage, it was essentially unchanged. And when we looked within the lung tissue, there was this almost paradoxical finding of there being less bacteria recovered with our CDK inhibitor. which led to the obvious question, well, actually, have we just inadvertently given an antibiotic to these animals but called it something slightly different? But when we looked at the growth curves of E. coli in vitro, with quite a wide range of our AT compound, there was no change in growth at all, and that's in comparison to some hydrogen peroxide as a positive control, which completely obliterated bacterial growth. And then to have a look to see what relationship augmented neutrophil apoptosis might have to all of this, we looked at a slightly earlier time point, just 6 hours after we'd given our drug, and at this stage, in both the lavage and the lung, there was augmented neutrophil apoptosis, and at this time point there was no change in bacterial burden, which suggested that at least temporarily the increased neutrophil apoptosis was occurring upstream to changes in bacterial clearance. So just to summarise that, thankfully, we were able to show that antibiotics are indeed a good treatment for pneumonia, and I certainly wouldn't suggest otherwise. What we found with our CDK inhibitor is that there was not just anti-inflammatory effects, but there was also this indirect antimicrobial effect seen in our E. coli infection, although the exact mechanism of this does require a little bit of further investigation. And in conclusion, this potentially opens a door for neutrophil apoptosis-inducing agents as treatments for infection-associated inflammation in humans. And finally, I'd just like to thank everyone that was involved in this, particularly my supervisors, Professor Adriana Rossi, Chris Hazlitt and Dr. Roger Duffin, everyone from the Rossi group, particularly David Dorwood, who was key to helping get set up with the E. coli model, the ECAT directors, Professors Iredale, Walker and Jackson, and also the Wellcome Trust for funding this work. So thanks for listening, and I'd happily answer any questions.